Hello, everyone. Thank you for joining us. We're going to get started at the top of the hour. Hello, everyone. Thank you for joining. Uh, my name is Shannon Kuhnberger. I am serving as a Chief Nursing Officer in Ohio. I am also a doctoral student with the IU School of Nursing, and I am working with Sigma Theta Tau International, partnering on my DNP project. And I'm really looking forward to today's webinar series. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau is accredited as a provider of nursing professional development by the American Nurses Credentialing Center Commission on Accreditation. The speakers and planning committee members have disclosed no relevant financial relationships to receive contact hours for this session. The participants, you will need to attend the full webinar and complete the evaluation form, which will be emailed to you to all the attendees approximately 1 week after the webinar. This webinar is being recorded and will be available to you a few business days after the recording. Following the presentations, if we have time, there will be a question and answer session. You will see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type any question you'd like to pose to the presenters. Be sure to hit send so that the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. This webinar proudly is sponsored by Emeritus. Learn from the world's best. Emeritus is committed to teaching the skills of the future by making high-quality education accessible and affordable to individuals, companies, and governments around the world. In collaboration with 2 leading healthcare institutions, University of California, Irvine and Emory University, Emeritus is excited to announce enrollment that is open for their new programs, the Chief Nursing Officer Program and the Chief Medical Officer Program. Please view this brief video from our sponsor.
Emeritus is proud to sponsor Sigma Theta Tau and the Rebuilding Healthcare webinar series. Emeritus is committed to teaching the skills of the future by making high-quality education accessible and affordable to individuals, companies, and governments around the world. By collaborating with more than 50 top-tier institutions to offer short courses, degree programs, professional certificates, and senior executive programs, we have helped more than 250,000 individuals across 80 countries learn new skills and transform their lives, companies, and communities. This fall, we are launching executive leadership cohorts in the University of California, Irvine Chief Nursing Officer and Emory University Chief Medical Officer programs. Learn more at emeritus.org/healthcare.
We would like to thank our speakers for their expertise with us today. Our speakers today are Melissa Rackmill and Dr. Emily Segal. Melissa Rackmill, MBA, BSN RN, is from Buffalo, New York, graduating from Trocare College with her associate degree in science, registered nurse since 2008. Not long after passing her boards and becoming an RN, she went on for her bachelor's degree in nursing at Dieuville College in Buffalo, New York. After deciding on her career path, she went on to further her education and graduated from the executive MBA program at the University of Buffalo in 2016. She is a mom of 4 and relocated from Buffalo to Rochester. When she accepted the position as Vice President of Patient Care Services and Chief Nursing Officer, the hospital is an affiliate of the University of Rochester Medical Center, and St. James Hospital is located in Hornell, New York. Emily, Dr. Segal, brings us 20 plus years of experience to the nursing profession and has served in a variety of roles in acute care, cardiovascular, nursing, education, care management, ambulatory, quality, and performance excellence. Emily is currently serving as the Vice President and Chief Nursing Executive at Community Health Network for Ambulatory Care, where she oversees nursing practice for over 200 sites of care across central Indiana regions. Emily earned her bachelor's degree in nursing from Indiana Wesleyan University in Marion, Indiana, and completed her master's in nursing education and doctoral nursing practice from Indiana University, Indianapolis. Emily is a board-certified advanced nurse executive and is finishing her second term as the president of the Indiana State Nurses Association. Welcome, and we will hand it over to you.
Thank you, Shannon, for the introduction and the opportunity to speak today. Again, my name is Dr. Emily Segal, and I'm the Vice President and Chief Nurse Executive of Ambulatory Care at Community Health Network in Indianapolis, Indiana. And as of 2 weeks ago, the immediate past president of the Indiana State Nurses Association. And today, I will be sharing how my organization has shifted to team-based care to align with value-based payment models in the primary care setting. A little information, the learning objectives are on this particular slide. I'm not going to go through them, but I wanted to give you a little more information about Community Health Network. Community Health Network is located in Indianapolis, Indiana. We have approximately 550 outpatient providers who practice in over 200 clinics across the central Indiana region. This medical group is known as Community Physician Network. We provide services across a broad spectrum of specialties as listed here on the slide. So what is team-based care? Well, the Institute of Medicine defines team-based care as the provision of health services to individuals, families, and/or communities by at least 2 healthcare providers who work collaboratively with patients and their caregivers, to the extent preferred by each patient, to accomplish shared goals within and across settings to achieve coordinated high-quality care. Now, there are many advantages to team-based care, and the American Nurses Association outlined some of these in an issue brief published in 2016. Increased access to care, more effective and efficient delivery of services, increased job satisfaction, and an environment in which all medical and non-medical professionals are encouraged to perform work that is matched to their abilities. So Mitchell et al. Produced this very nice outline of the principles of team-based healthcare. And when Melissa and I met to review our presentation, we both agreed that these principles were all very key to leading this work in both of our organizations. And as we share our journeys with you, I think you'll find all of these principles woven throughout our presentation today. The main ones I'll point out is you'll hear a lot about clear roles and making sure that there's delineation in roles, mutual trust between providers and staff and leadership. And then the other important one you'll hear in both of our presentations is around measurable processes and outcomes and the importance of being able to measure those. So how did we arrive at team-based care in our organization? Well, value-based care payment programs, which are linked to quality outcomes, have been the main driver for this change over the years. However, the pandemic was what truly accelerated this work for us. During the pandemic, we were forced to look at our staffing models differently due to earlier than anticipated retirements, nurses leaving for travel positions. Our virtual care visits also increased from 10% to 70%, and our MyChart advice messages doubled as patients began to really embrace technology during the pandemic. During the first part of COVID, we also shut down our clinics and sent staff home to work. And lastly, the Indiana's Nurse Licensure Compact went into effect on July 1st, 2020, which allowed nurses to practice in other compact states. There is no question that healthcare workers across the globe experienced trauma during the pandemic. And when one experiences such trauma, it's not uncommon for them to start really reevaluating their life, their values, and their goals. And what we've seen is that this kind of personal reflection has resulted in a much more larger emphasis on work-life balance and equitable pay practices. We are seeing many requests for part-time positions, flexible hours and shifts, whether that's 4-10s, or maybe they want to come in at 5 a.m. and leave at 2 p.m. because they have to pick up their children from school. And they're also looking for more work from home opportunities. Now, some of this phenomenon can be contributed to generational nuances. And as we know, our younger generation of nurses have similar expectations coming into the workforce. But during the pandemic, you may recall stories of nurses who sold everything they had. They might have purchased a pull behind or an RV or a van and worked remotely and traveled around the country, or took travel nursing assignments for 13 weeks, and then would move to the next state and do another 13-week contract. Here in the state of Indiana, we saw some also take advantage of the new compact licensure and move to other compact states for work. We also know nurses who left the field completely to open their own business or to get out of the medical field altogether. And one of my friends recently actually saw a former colleague behind the counter at an ice cream shop. And she said, "Well, what are you doing here?" And her former colleague said, "I had to get out. It was just too much." And so that's kind of eye-opening. Lastly, when we sent our clinic nurses home to work, they soon realized that they can be just as productive working from home. And when we asked them to return to the clinics, they wouldn't budge. They did not want to come back. And if you've not been online lately looking at job postings, you will find numerous work opportunities for nurses to work from home all across the country and even globally. We are also seeing this trend in other roles, such as medical assistants in our offices. And during the pandemic, Community Health Network, we went from 70 medical assistant openings on average to 120 medical assistant openings in a 2-year span. Again, these staff were also wanting more flexible schedules and more work from home options. Now, when you look at this table, and this is our data from our particular ambulatory outpatient services at Community Health Network, you'll see that we've actually increased the number of RNs that we have and LPNs in our ambulatory space after the pandemic. So you're probably saying, "Well, Dr. Seago, but if nurses are leaving, how do you have more nurses now than what you did before?" And so this is really a result of two things. One, many nurses transferred to the ambulatory care side during the pandemic due to burnout and wanting better hours. So they left acute, came over to the ambulatory side. But two, this all goes back to implementing team-based care models. As we implemented our team-based care models, we were able to create more RN positions with the kind of flexibility nurses were looking for. So how did you get more RNs through team-based care models? Well, let me take you through the journey thus far that we've had. we began working on what we called primary care reimagined. This was a result of a collaborative business plan that proposed changes to our model it was actually over a 5-year period of time, which COVID actually accelerated. So we've done a lot more work in the first 2 years than what we had anticipated. But listed here are the components within that business plan. And as you can see, this is a large body of work. And while team-based care appears to be just a small portion of the bigger vision, you can see or imagine how all of these components intertwine and how the success of one component might be dependent on the success of another component. So this truly demonstrates just how complex and challenging implementing team-based models of care can be, and that it cannot be done in a vacuum or in isolation. As a catalyst of this work, it was my job to help look at team-based care models and create a plan. In ambulatory care, there is not a whole lot of research on this particular topic. Much of the work published is really related to team-based care on the acute care setting. In the acute care setting. Considering this work was taking place during COVID, and I was actually new to my role in ambulatory, I decided to start with a current state assessment, which really allowed me to go to the offices, talk with the staff, understand how our practices were truly operating. And what I found was that some of the offices had no RNs or LPNs, and if they did, they might have only had one. And they were often doing a lot of medical assistant work. And this was what I found to be true also before the pandemic even started, is that the RNs were not really working to the top of their license. We were also cross-training medical assistants to function in the front office, which they told me they were very dissatisfied with. And in some of the exit interviews we saw, that dissatisfaction really come out. Medical assistants were also taking triage calls and processing MyChart advice messages in some offices, which is not ideal since medical assistants are unable to assess patients. They then have to forward those on to the providers or a nurse for further review. And this was really causing burnout among our nurses and providers. And if you remember or recall me saying that we had a 17% increase in MyChart utilization during COVID. So it's putting a huge strain on our nurses and providers. But I think one of the most eye-opening things that I discovered is that there was only one role summary in ambulatory for a staff RN. And that role was very focused on tasks such as giving vaccines and doing blood pressure checks. So to summarize my assessment in a few words, no one was really working to the top of their scopes. There were no defined or clearly delineated roles, and everyone was doing a little bit of everything. The nurses, if they did have one, were wearing multiple hats and trying to be everything to everyone in the offices. After the assessment was completed, a multidisciplinary team came together and mapped out where gaps existed in nursing roles and divided out tasks that aligned best with each role based on scope of practice. And in doing this work, we really had to carefully look at the MA role in the state of Indiana, which was a little challenging due to many gray areas in their scope of practice. So we resorted to our American Academy of Ambulatory Nursing, which had some great resources online that was very helpful as we created our future state as well. And in doing that work, as you can see, this work led to the creation of some new roles using a team-based care approach, including an ambulatory patient care tech, a triage nurse role, and a collaborative care RN role, which was a role created from a HRSA grant that we had received and had been piloting. These two diagrams illustrate the evolution of our team-based care model over the last 2 years. And in 2020, you can see how skinny our care team was, and then you add staffing challenges onto that. And you can imagine the care that delivery of our organization with our patients was just probably not optimal at the time, and the gaps that existed, which are not conducive in a value-based care model at all. The team-based care model is much more robust and truly fills in the gaps in care. And some of you may remember the development of the patient-centered medical homes many years ago and might see some similarities between the two models. So a little more on the new roles that we created to create this team-based care model. First, the ambulatory patient care tech role. This role is cross-trained to both front office and back office duties, which offloads tasks from the medical assistant that can be done by a trained lay person, such as vital signs, phlebotomy, and rooming of patients. And this allows the medical assistant then more time to work on quality gap outreach to our patients and conduct virtual rooming from home for a better work-life balance. It also provides some front office staff with the opportunity to expand and grow in their own role. And then the collaborative care RN is an RN that conducts enhanced nursing visits and works closely to close quality gaps with patients, focuses on wellness and prevention through health coaching and motivational interviewing. They collaborate with pharmacists, dietitians, and providers, as well as social workers. They do a lot of care coordination, navigation. They manage social determinants of health referrals. And this particular role really allows the RN to work at the top of their license. And we made this role so it's about 75% in the office, and then they can take a day at home and work virtually as well. And lastly, we implemented a triage RN, an LPN role. We had a few LPNs. We are trying to move to an all RN model for triage. But we did grandfather in some LPNs that had been working for the network for quite some time. And this particular role is dedicated to triaging symptom-based phone calls using protocols so that patients' needs can be handled immediately rather than passing them along to a provider for intervention. They also manage MyChart advice messages in Epic, again, using protocols. Schmidt-Thompson protocols is what we use. And this offers work from home option and flexible scheduling options as well. And just to give you an idea of how popular this particular role became, we actually had to shut down our postings within 12 hours because we just had so many people applying for this particular position due to the flexibility and work from home option. Now that I have shared what we did to help shape team-based models of care in nursing, I want to mention another evolution in our team-based care model with our ambulatory dietitians. Prior to COVID, our dietitians were all assigned to a specific office or location and only took referrals for that location. But once they started working from home during COVID, we found that their productivity went up 33%. And so the decision was made to centralize the dietitian team and create one referral pool for referrals, and which will allow the dietitians then to take referrals throughout all of ambulatory. And we were able to then increase access for patients, which is, again, one of the advantages of team-based care. These roles are also all work from home, which worked out nicely, actually, because we were trying to integrate the new tech role and the collaborative care RN role, which we needed seats in the offices for the staff to sit. So after 2 years in the making, here are some lessons learned, and I think you'll find these to be quite similar to what Melissa will share with you in her presentation as well. First and foremost, get buy-in at every level. If you only have 25% buy-in, you may want to consider holding off and waiting. Cultural readiness is very key. But you also have to realize that buy-in will never be 100%. You're going to have some people that just can't seem to get on board with this concept. And that's okay. You just have to stay the course and move along. You need to partner with finance. That's very key. We're always looking at ways to capture that return on investment, and we all know that money talks. So in nursing, a lot of times we're not revenue generating, and so it's a little harder to go to labor team and get those positions approved. Also, setting KPIs or key performance indicators and develop your dashboards to capture baseline data and post-implementation data. Being able to measure and share your outcomes is very key. And then leveraging champions to move that vision forward, especially providers. I think those were the hardest to get on board with some of these concepts. And we'll talk about trust in a little bit later in this presentation. But also investing in resources and nursing leadership infrastructure to support these new roles. For example, when we developed that new triage role, we decided, oh shoot, we need an educator now to produce a training curriculum, making sure that we have orientation and onboarding processes put into place for those new triage nurses. And this is not a sprint, it's a journey. It's a very long journey. And we are actually still on ours even after 2 long years. And we have a long way to go. It's not something you want to rush. You want to go slow to go fast. And you may fail a few times, and that's okay. That's okay. So remember how I mentioned that this work cannot be done in isolation. Here are a list of key stakeholders that helped make our work successful, and we couldn't have done it without these people. And that is our providers, of course, our practice leadership, our staff. So all of the staff that have to now work together and are being placed together to work on patient issues, they all have to be on board with this work. Finance was huge. And then the EMR administrators, they were key. And when we were developing these roles, there's a lot of security and access issues and templates that have to be created for new roles. Analytics played a huge key in our outcomes and developing dashboards for us so we could show, where we were baseline and where we are now post-implementation. And then, of course, our human resources and clinical education department and recruitment teams, because we had created these roles, we needed some people to help us with the education piece and the recruitment piece as well. And project management, you can't live without a project manager. Ours did a wonderful job of keeping us on track and meeting our timelines and deadlines. So where are we today? And what are the strengths, weaknesses, opportunities, and threats of this model from our perspective? So let me talk a little bit about strengths. So strengths, I would say that first, it helped our staff really work to the top of their scope. And then it created more work from home positions. We were also now able to really leverage our compact licensure to retain and recruit nurses for triage. We were able to recruit from other states with that compact license. We had nurses living hundreds of miles away, or nurses who decided to move out of Indiana and go live in a compact state that could then remain in their triage position. Also, the centralization, as I talked about with our ambulatory dietitians, allowed us to then expand our services and our referrals for dietary needs. A few weaknesses, as we worked through these processes, we had our triage protocols, but the one set of protocols we realized quickly we didn't have is when you start to integrate a collaborative care RN role with a pharmacist and a dietitian, and you have, let's say, a diabetic patient, you really have to set some triggers for at what point do we give that referral to the collaborative care RN, and then they pass that patient offer to the pharmacist, or at what point does it negate to then bring in a dietitian? So we're still working on some of those protocols. And then we had several groups working, and you can see again on the slide I shared earlier on how those teams could potentially intertwine and work on some of the same things. So we did have some duplication at times. And then our current practice management structure for our clinics doesn't necessarily require a registered nurse to lead those clinics. And so sometimes you really have to have good influential skills in order to explain why nurses or medical assistants need to be working at the top of their license, and having some really key discussions as we work through this process. Opportunities. We have found that now that we are integrating an ambulatory patient care tech, we have a huge opportunity to incorporate now virtual nursing into our clinics, to where the tech can do a lot of the rooming, taking the vital signs and such, and the medical assistant can actually be working from home virtually, and then helping after that patient then is roomed, helping go in and then ask questions and making sure that the patient's quality gaps are closed, all remote, which obviously provides them more work-life balance. And the other opportunity that we have that we're working on right now is reimbursement for RN visits. We know across the country there are lots of organizations where their RNs are actually billing for their services, whether that's for annual wellness visits or complex care visits. And so we are currently piloting billing for some of those services. And then some of the threats, of course, when we talk about collaborative care RNs and coming in and doing some more complex care visits and working with patients, it does take some provider buy-in and trust on that level. And so that has been a challenge. We also have some leaders that really have not adopted the idea of staff working from home yet. And so that's been a huge struggle. COVID, I think, has hit us hard financially. I think most organizations are kind of suffering at this point. And so, trying to get some of the resources you need has been a little difficult. And then also we just have to, one of the threats we have to look at is physician comp. Are some of our physicians still working on an RVU model, or have they crossed over into that value-based model? So when you have some of them in it and some of them not, it does become a little bit of a challenge when you're trying to integrate the team-based care models throughout the organization. And then again, a need for infrastructure and resources to support new roles is very, very important. There were things that, we wish we would have thought of and we didn't. But we were able to get on track, but there's still some more resources that are needed that I think that, again, budget constraints sometimes can be a barrier. So this concludes my portion. Thank you so much. And I'm going to turn it over now to my co-presenter, Melissa Rackmo.
Hello, good afternoon, Emily. Thank you for your portion of the presentation. I will move on to mine. Thank you for the opportunity to present today. I've been looking forward to this presentation. So I'm going to move forward. My model is the team-based model, development of a triad staffing model, and this is from an acute care standpoint. So I'm going to give a little bit of a background of my organization and my hospital. So my hospital is an affiliate hospital of the University Rochester Medical Center. St. James Hospital is located in Hornell, New York. It's a very small rural community hospital. And when I say very small, we have 15 inpatient med-surg beds, 4 observation beds, 9 emergency department bays, 4 operating rooms, imaging services, lab services, and a multitude of outpatient services, which are located in our medical office building, which is connected to our hospital. We offer primary care, women's imaging, urgent care, physical and occupational therapy, orthopedics, and we have a specialty clinic with a multitude of specialties listed there. So what is a triad staffing model? A triad-based care model is a staffing model of care provided to patients in an acute care setting. The triad or team nursing model includes RNs, LPNs, patient care technicians, working together to provide care to our patients while decreasing the number of RNs needed for a safe nurse-to-patient ratio. This model allows RNs to focus on care other than the tasks related to their job and related to nursing care. Additionally, it allows our LPNs to practice to the top of their scope of licensure. So the history of team nursing. Team nursing is a historical staffing model. The history of the model, it was called the team nursing model and was developed during the era of World War II. RNs and CNAs, or certified nursing assistants, work together to provide care to patients. For some reason along the way, this model was minimized at some point and retired. There was thought that RNs caring solely for patients would increase the quality of patient care delivery, which has been found to not be true. And previously, when I have worked with team nursing, when I first started as a nurse on the floor, we utilized LPNs, but they were utilized more as CNAs and not utilized to the top of their scope of licensure. So team nursing model versus triad nursing model. The history of the team nursing model limited the RN and CNAs. The triad staffing model has a modern twist. It incorporates a team model, but adds LPNs to the patient care team. For every 7 to 8 patients, there's an RN, an LPN, and a shared patient care technician for the entire unit. We are, as I had mentioned, a very small rural community hospital. Our med-surg unit has 15 beds. So for this 15-bed unit, the model is as such with 2 RNs, 2 LPNs, and 1 shared patient care technician. The LPN in this model, they're able to work to their full scope of licensure, administering IV medications, and starting IVs, administering medications by mouth, etc. And we refer to the New York State Department of Education scope of licensure for following along what their scope is. By adding the LPN to the care team, they feel valued and respected as a nurse in the profession. They feel that they're truly an integral part of the team, which is what we wanted to happen. So our staffing model prior to, it was a 15-bed med-surg unit. It was staffed with 3 RNs and 2 patient care technicians, which was a 1-to-5 nurse-to-patient ratio. However, if you have a call-in on the unit and you're not able to staff that whole, you then turn into having 1-to-7 or 1-to-8 patient ratio, which ultimately is not safe, especially in our small rural community hospital. I feel as though we have less resources than larger hospitals. And staff, because we do not have an ICU in my hospital, also care for higher acuity patients as well. How did we get here? How did we decide we were going to go along the lines of a triad staffing model? Now more than ever, nurse executives are being challenged to create and develop creative out-of-the-box solutions for staffing and retention. Our staffing challenges as a small rural community hospital weren't new prior to COVID. They were just expedited. We were developing our staffing model prior to COVID, and our staffing issues have been exacerbated by the pandemic. In New York State, we also have the requirement for the vaccine as well. And so we had lost staff along that also. Recruitment and retention, we recruit and we get the staff here, about how do we keep them? The staffing model allows our staff to function as a team instead of an all-RN and non-licensed nursing assistant. This allows our RN and LPN staff to share the tasks of nursing so they can feel again like a nurse, that they could really get back to the bedside, talk to their patients, provide the care, put their bedside socks on, put lotion on their patients, the things that we used to do as nurses that sometimes now, because we're so task oriented, you don't really feel like you can do. Benefits of the model, there were multiple benefits. However, the model was developed to enhance the overall patient safety and quality of care delivery through the use of staff members working to their full scope of practice in a collaborative team environment. Risks: securing and training staff prior to the staffing model implementation. We had hired some LPNs, not all LPNs. Where were we getting the LPNs from? Were we stealing from our clinics to staff our med-surg floor? Are we taking from our nursing homes to staff our LPN staff? And how is that going to affect the downstream effect? Is we have now patients holding an ALC status that don't have beds to go to for rehab or long-term care. And those challenges are there even more so from the pandemic. Assuring that our nursing staff understood the why behind the change. So really taking the time to have conversations with our staff, open forums about, this is our current staffing model. This is what we're thinking of going to, and this is why. This is how it's going to help you. Ensuring our team has trust and confidence in one another. So really the RN has oversight of the LPN, but how do we assure that the RN trusts the LPN in their scope of licensure and the tasks that they're doing? So we had to really work on that, assure that they knew and understood the scope of an LPN, and have them develop relationships. Communication, availability, and active listening by the nursing leadership team. If we didn't have this available, this model most likely would not have been successful. It was a lot of communication, a lot of active listening, and reassuring our team that this was for the best interest of not only our patients, but for our staff as well. Phases of implementation. Open staff forums, as I had mentioned, about staffing and possible solutions with our frontline staff and to gain staff buy-in. Emily mentioned this as well. The staff buy-in is extremely important because I could say, this is the model we're going with and we're moving forward, or I could sit down and have a conversation, explain the why, listen to their concerns, and have answers for them to mitigate those concerns. Provider buy-in. Our providers are very active in our quality of care delivery, so wanted to assure that our providers were also on board with the model and understood the scope of licensure of an LPN as well. That was very important. I developed a business plan. This was actually a business improvement plan, and this was worked on with the administrative team and our board of directors for approval. This also was a business improvement plan because the thought was by implementing this model, we could decrease the number of travel staff. And as we all know, throughout the pandemic, the cost of travel staff has almost doubled. It's quite high and it's unsustainable for a hospital, especially a hospital of our size. So we had to hire and train the LPN staff, assuring that everybody was clear on their scope of practice. And some of the LPNs that we had hired and trained were coming from clinics and were coming from nursing homes, not necessarily working truly to the top of their scope of licensure. So we had some skills that we had to teach and assuring that their scope of practice in an acute care setting was understood on all ends. Educating our patient care technician or our nurses aid staff on their role and assuring that they knew that they're still an integral part of the team. As you'll see, this is an area that I wish that we had addressed ahead of time. This was kind of caught on the back end. And the patient care technicians at first had felt like they were no longer needed. You know, if you're going to bring in the LPNs, do you still need us? Are we still a part of this team? So those issues were addressed and identified, and we really had to assure them that their position's not going anywhere. They are still needed to care for our patients. RN education as well related to the LPN scope of licensure and also delegation. RNs have always delegated to our patient care techs, our nurses aides, but assuring that our RNs felt comfortable delegating with what they could delegate to LPNs. This is just a visual of our triad staffing model for our unit. And this is LPN scope of practice per New York State Department of Education. When we initially rolled out this model, we did not have the LPNs do anything with IVs. There's some gray areas with IVs, so we wanted to make everything to start very black and white of this is what you can do and this is not what you cannot do. And since then, we have implemented where our LPNs can start IVs and can change IV medications as long as it's not first dose IV medications nor high risk medications. So that's where the gray area comes in. We have just rolled that out. This has been implemented now for 18 months and still working wonderfully. And we had just recently rolled out adding in the IVs. So the outcomes of our triad staffing model, we have found that this improves our patient experience scores, improves staff engagement and satisfaction. Very rarely are our staff working short-staffed. Decrease the use of external travel agency staff. I think we are down to 1 RN traveler on our med-surg floor at this time, which is a huge change. We had about 6 or 7 prior to this. There's a cost savings here, not only because we decreased the number of FTEs of RNs, and I just want to clarify, we did not lay anybody off. We actually had those positions open. So we just had cut contracts with travel staff as close to the end of their contract as possible. So we saw a cost savings there, and then also cost savings between the pay difference from RN to LPN. And this really is a safe, high quality patient care delivery system. So it's been working very well. Just to give you an idea, I wanted to highlight some of our increases of patient experience scores. Our overall patient satisfaction scores are showing that we're in the 87th percentile ranking for rate the hospital 0 to 10. Our lowest point prior to, and I apologize, this isn't last year, it was prior to the implementation, we were the 9th overall percentile ranking. Nurse communication last year was in the 6th percentile, and this year has reached the 44th percentile. Communication about medications last year was in the 16th percentile, and this year has improved to 45th percentile ranking. This year's responsiveness of hospital staff score has reached the 43rd percentile from last year's 22nd percentile ranking. There's still much room for improvement here, and I absolutely recognize that, but definitely proud of our team and the progress that we've made in these areas. Lessons learned. I think I talked through a lot of these, but I will bring them up again. All of our staff should be hired and trained prior to the model being fully implemented. We did hire and train some staff and still had some open positions. So we were still filling in with RNs when we were trying to roll out a new model. It was a little bit confusing for the staff at first. So I think having staff hired and trained prior to rolling out the model would have been extremely helpful. Include patient care technicians in the education prior to implementation so that they have a sense of security, and assure them that they are an integral part of this care team. We have increased the LPN care to fully recognize their scope of practice. And it was a challenge for the RNs at first to see past the number of patients they would have with the model prior to it being in full swing. So I heard over and over, I'm going to have 7 or 8 patients. I'm going to have 7 or 8 patients. You have 7 or 8 patients, but not by yourself, with a team. There's an LPN assigned with you, and they could take off a lot of the tasks so that RNs can really get back to the bedside and feel as a nurse. In conclusion, nurses are leaving the profession from fatigue and burnout. It's our job as nurse leaders to utilize out-of-the-box staffing ideas and to provide support to our nurses and retain the dedicated patient care staff that we have. So finding ways to do that. Emily mentioned the flexibility for jobs and being able to work from home. In the acute care setting with this model, we're not able to do that, but being flexible with staffing, assuring that when they come to work, they know that they're going to be fully staffed, and that's been really successful. In addition, this allows us the opportunity to uphold the commitment to our communities by providing them with the highest standard of care. And that concludes my presentation.
Thank you, Melissa and Dr. Sego. We've had excellent questions in the question and answer section, and we are attempting to answer many of them. We do have a little bit of time for questions, and so we'll kick that off. And I'll start with you, Dr. Sego, related to your new nursing roles and just the new model that you have. Did you, have you been able to identify that you have a reduction in your turnover or an increase in your retention based on this new model?
Yeah, so for the actual triage role itself, I will say after a year and a half, it took us a year and a half to lose 1 nurse. So we were at probably, I would say, about an 18% turnover rate at one point. And then when we went to this triage model where we had delineated role for a nurse to sit and do calls and my chart advice messages, that went down to about 10%. So again, it took about a year and a half for finally one of the nurses to leave, and they left for another work from home position that paid more at Anthem. So
you can't win them all, and those actually, given the current climate of turnover and retentions, those are pretty impressive.
And I would say to one other, I think, factor that helped that, not just the flexibility of staff, but these nurses were actually moved under nursing administration. They were working under the practice leadership. And then when we went to this triage model, we felt that it would be best that nurses were helping train, educate, and support those nurses. And that's what they really felt like, wow, I feel like I have better nursing support being under nursing leadership. So.
Sure, excellent. And so along the lines with the caregiver engagement and satisfaction, let's talk about, if you don't mind, on the patient side, as patients understanding their trust and working with MAs and then RNs. And can you share a little bit about how this impacted the patients? How did they receive it, and their experience?
Yeah. So after actually a year, one of the things we really wanted to focus in on is the satisfaction around the triage model first, because our physicians, that was probably the biggest contention with our providers was, you're taking my nurse now and you're putting her on a phone line, and so we felt like we really needed to show the providers the value of this triage nurse to the patient. And so far, we actually just got our first set of data points back in August. And when you looked at, we used a Likert scale and asked a lot of questions about, how were your needs met within, that same phone call, or did you have to call multiple times? Did you trust your nurse? And 86%, when you look at the experience overall for the triage role, 86% of the patients scored that they, very much, I can't remember the exact term on the survey, but overall, they were very satisfied with their triage process. Beforehand, I want to mention that they were using voicemails. So when patients would call in, if the nurse was busy doing other things, that patient would go to a voicemail, and these were all live answered. So that made a huge difference in their satisfaction and the turnaround times on getting their patient needs met.
Excellent. And we are going to flip over to Melissa here, but I have one more question. I think, Dr. Sego, that I saw in the Q&A was about your technology component. Were you utilizing telemedicine and or are patients owning some of that triage process themselves, such as taking their own vital signs? What does the hardware and technology side look like in your organization?
Yeah, so a couple things. One, during COVID, we used our product that actually sits within our Epic system. And during those types of telemedicine visits, sometimes they had to take their own blood pressures if they had a cough. We did produce kits and mail them off to patients at times if they didn't have those things. Now, post-COVID, we have moved into this now, talking with a vendor about virtual nursing, in which I mentioned in the presentation, where we will have exam rooms set up with machines in the exam room that can take blood pressure, weight, those sorts of things. Now, not every patient is going to be able to do that. If they're elderly, they are going to need some help. And that's where that patient care tech kind of comes into play. So we are working with a vendor to help get that medical assistant at home and being able to then key in virtually into the exam room and do their part.
Excellent. Thank you. Just positive and innovative. And so congratulations. And we're going to flip over now into the acute side with Melissa. Many questions, and they're still coming through. So we'll start off with probably the first one is, what education did you need to do to ensure that the RNs could lead teams? So talking more about that delegation training and for the RNs to lead a team.
Sure. That was an area that we actually identified ahead of time, especially because the RNs previously were delegating to non-licensed staff, the patient care technicians. So we did develop an education based around delegation from the RN to the LPN and patient care technician as well involved in that. And that was rolled out prior to the implementation of the model itself.
Great. And did you find that there were different challenges with novice nurses when it came to being a leader side of a team?
So I think there was some discussion about that. There was discussion about our newer nurses, our newer grads coming in and delegating to the LPNs. But again, I think that delegation portion of the prior to the rollout and the just gaining a comfort with the new model, I think was helpful.
Great. There's definitely a lot of questions. If you wouldn't mind recapping of what was your nurse ratio prior to this change to where you are now?
Sure. So our nurse ratio prior to was 1 to 5, as long as we were fully staffed that day. Otherwise, it was 1 to 7 or 1 to 8. Now with the model, they do have a 1 to 7, 1 to 8 ratio, but they are teamed with the LPN. So they're caring for 7 or 8 patients, but they're not caring for those 7 or 8 patients by themselves. The LPN could help take a lot of those tasks off of their shoulders.
Thank you for that recap of that. There is definitely a question when you do these staffing. Are you staffing based on acuity?
So the model itself doesn't have staffing for acuity. However, our nursing supervisors are very good with identifying when there's highly acute patients. If we have a drip on the floor or something like that, as I had mentioned, because we don't have an ICU, a lot of times we transfer patients out, but if we can keep them, we do. So if we have a cardosem drip or an amiodarone drip or something like that, our nursing supervisors reach out, get approval to call somebody else in to the floor to assist and to break down the floor a little bit more so that the care is not 1 to 7 or 1 to 8 with the LPN. So we break it down further.
Great. Great question. I'm seeing a question here, and I'm wondering if that is global. In most states, nurses have to do the initial assessment charting on every patient. Has that been a challenge when you have a load that is 7 to 8 patients?
No, I don't think so. Our nurses do the initial assessments. They do the assessments on all new admits to the floor as well. And I think because the LPNs can help with the tasks as far as administering the medications, I think that's been mitigated through that.
Excellent. Hot off the presses. Is there a transitional care coordinator with population health department post-hospital for follow-up in part of any of your teams?
So for ours, we work with our, again, very small rural community is kind of a bonus here. We work very closely with our primary care office, who has care management, and then our care management team in the hospital connects with the care manager in the primary care office, and they have a process to assure transition of care.
Great. I think we can apply that to Dr. Sego as well.
Yes, we actually do. We do have transitional care nurses, and they will see the patient and then they hand those off to our collaborative care RNs and work very nicely with the collaborative care RNs in the offices.
Great. Excellent. All right. I'm trying to see if we've got anything else. Is there anything else that you guys would like to share that's come up where you're seeing through the questions?
I think a lot of the presentation showed the rainbows and butterflies portion of this. And of course, there's always bumps in the road. And I hope that I help identify some of those bumps in the road with the look back at, what I would have done differently or whatever it may have been. So every change is a change, which is a challenge ultimately. But I think for where we're at, this has been a great asset to our team.
That's an understatement. I think what we've learned the most probably through COVID is that it's going to constantly be changing, and being agile and adaptable is really going to be key. All right. Okay, Melissa, how do you measure staff engagement related to this team model?
We actually utilize a staff survey for engagement and satisfaction of our staff through Press Ganey, and we have recently rolled out the survey, so waiting to get the results on that.
Oh, great. Excellent. Well, I wish nothing but the best success on that. Go ahead.
I can kind of answer too for triage nurses. We sent out an engagement survey as well. And the interesting part about that response was, these nurses really wanted to work from home, but then I think they felt a sense of mourning because they were like, I'm no longer working with a patient every day. And every now and then I want to just come in and, see a patient. And so we did allow them through that survey then to, if they wanted to, they could do a hybrid approach and come in and work in the office 1 day a week and then work from home the remainder, or whatever they came up with creatively to that. So that way they would keep those skills up. Because I think they were really worried that now that I'm home, am I going to lose my skill sets?
Yeah, I think that probably can go across all industries, right? It's almost like the honeymoon is now over. This joy of wearing, casual clothes and hiding out in homes, and you're like, wow, I do need to go and see people and get fulfilled and find joy. So I appreciate that commentary. We're going to wrap it up here. I want to say thank you so much to our presenters today for all of the great information. Sigma Theta Tau is grateful that you took the time to share with the audience, hearing more from you in the future. I hope we have an opportunity to share your information if any of the participants would like to seek out further information. As a reminder, 1 week from today, we will email you the link to the evaluation for you to obtain your continuing professional development certificate. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. We have 2 remaining webinars coming up in this series of Rebuilding Healthcare. Be sure to check those out. And we really thank you so much for joining us today, and have a wonderful day.
Thank
Thank
you.
you.